Let's talk about pituitary stalk lesions, or PSLs. If you're an endocrinologist, you know that seeing this on an MRI, well, it's a real puzzle. So in this explainer, we're going to build a clear framework to help you tackle it.
So let's put ourselves right in the clinic. You get an MRI report back, and there it is, a thickened pituitary stalk. It's an incidentaloma. You weren't even looking for it. But that one little finding, it just blows the doors wide open to a huge list of possible diagnoses. The big question is, what's your next step?
Okay, so here's how we're going to break this down. First, we'll get to the heart of why this is such a tricky problem. Then, we'll unpack all the different things that can cause it. After that, we'll walk through a solid diagnostic plan, check out some real-world cases to see how it all plays out, and finish up with the key takeaways you can use in your practice.
Right, so first up, the stalk lesion conundrum. What is it about a thickened pituitary stalk that makes it such a headache for clinicians? Let's really dig into why this is such a big deal.
You know, the core of the problem is just how many things it could be. You've got this one finding on an image, a thickened stalk, and it could be anything. We're talking inflammation, something someone was born with, or, and this is the scary part, even a serious malignancy.
And you might think, oh, that sounds pretty rare, but check this out. It pops up in as many as 0.2% of all head MRIs. It might not sound like a lot, but in a busy clinic, trust me, you're going to see this.
And listen, this is way more than just a weird thing on a scan. Here's the real clinical kicker. A staggering 94% of these patients, even if they feel totally fine, have some kind of underlying hormone problem. That's why a full endocrine workup isn't just a good idea, it's absolutely non-negotiable every single time.
All right, let's move on and start unpacking the causes. We're going to look at what's behind that thickened stalk, from the usual suspects to the real zebras. And believe me, the list is pretty wild. So when you look at the big studies, what do you see? Well, for a huge chunk, about 42%, we actually never find the cause. It just stays idiopathic. But for the ones we do figure out, tumors and inflammation make up half the cases. And that right there is where we really have to focus our attention.
And if you look closer at those categories, it gets even more complicated. I mean, under neoplastic, you've got germinomas, but you've also got mets from lung or breast cancer. And inflammatory, that could be anything from autoimmune hypopituitaritis to sarcoidosis or even TB. It really drives home the point that the MRI is it's just the first clue in a very long detective story.
So with all this complexity, where do we even start? What's the smartest, most logical way to work through this massive list of possibilities? Let's lay out the pathway.
The absolute key is to have a system. You got to go step by step. And step one, always, is a complete hormone check. I'm talking anterior and posterior pituitary. Don't even think about the next steps until that's done. Then you can start looking at the MRI details, do a broader systemic workup, and think about that very tricky decision, whether or not to biopsy.
And speaking of the posterior pituitary, you really have to zero in on it. Why? Because the rate of arginine vasopressin deficiency, central diabetes insipidus, is just incredibly high in these patients. We're seeing it in anywhere from 28% to a whopping 72% of them. That is a huge deal, and it's a diagnosis you absolutely cannot miss.
All right, let's talk imaging clues, because the MRI can tell you a lot. The way the stalk is thickened is a big hint. If you see a nice, uniform, smooth thickening like in this drawing, your brain should immediately start thinking about inflammatory stuff, like hypophysitis or sarcoidosis.
But on the flip side, if you see a more V-shaped or kind of lumpy nodular pattern, that's when the alarm bells for a tumor should start ringing. We're thinking especially about things like metastases or germinomas. Now, it's not a perfect science, there's definitely some overlap, but these patterns are super important for pointing you in the right direction.
And all of this leads us to what is without a doubt the toughest call you have to make in this whole process. Do you go for a biopsy? This is a huge dilemma, and it's something we all struggle with.
And it's a real balancing act, isn't it? On one side, the biopsy itself is risky. I mean, almost half of patients, up to 46%, can end up with new pituitary problems after the surgery. But on the other side, what if you don't biopsy? You could miss something like a germinoma, a cancer that's very treatable if you catch it early. It's a classic rock and a hard place situation.
Yeah, take this quote. It's from a case where the first biopsy came back as just inflammation, lymphocytic hypophysitis. But the clinical picture didn't quite add up. They kept digging, did a second biopsy, and guess what? It was a germ cell tumor. It's a really powerful reminder that even tissue isn't always the final answer.
You have to trust your clinical judgment when things don't fit.
But you don't always have to biopsy. Not at all. Think about the classic counterexample. A patient who just had a baby presents with DI and a thickened stalk. That's textbook autoimmune hypophysitis. In that case, they were able to manage her with just medication. No surgery needed. She did great, and they completely avoided all the risks of a biopsy.
Okay, so let's boil all this down. What are the absolute must-know, key takeaways? The things you need to have in your back pocket the next time that MRI report lands on your desk showing a thickened pituitary stalk.
All right, here we go. First, and this is crucial, treat every single PSL like it's an endocrine problem until you prove it's not. That means a full hormone panel, no exceptions. Second, you have to specifically look for AVP deficiency. It's just too common to ignore. Third, never forget how huge that list of possible causes is. And last but not least, be really selective with that biopsy. Only do it if you're sure the answer will actually change how you treat the patient. And remember, these decisions are always better when made with the whole team.
So I'll leave you with this question to think about. Our imaging is getting more and more sensitive, which means we're finding more and more of these little incidental things. As that happens, our responsibility gets bigger too, doesn't it? How do we find that perfect balance between digging for a diagnosis and sticking to that most important rule of all? First, do no harm.